my name is Autumn Bennett, and I'm going to be talking about economic inequality in healthcare. The issues that arise from economic inequality is that health outcomes can be linked to levels of economic inequality, and greater economic inequality appears to lead to worse health outcomes. High income versus lower income diversity is an issue. Higher income inequality obviously tends to have lower average life expectancy. High income equals good healthcare plans, and low income equals restricted healthcare. Those who do not make as much are not given the opportunities of healthcare that are more privileged. An organization that helps with this issue is one that is called the World Health Organization, or WHO for short. The World Health Organization is working with 194 member states across 6 regions and more than 150 offices. WHO is a staff that is united in a shared commitment to achieve better health for everyone, everywhere. Their work over time focuses on sustainable financing, improving essential medicines, training new healthcare and workforces, supporting people's participation in national healthcare, and improving and monitoring data and information regarding healthcare. They address human capital across the life course, disease prevention, mental health promotion, climate change in small islands, antimicrobial resistance, and elimination and eradication of high-impact diseases. They have created a new program called the 13th General Program, and it is a 5-year program ranging from 2019 to 2023. They focus on 3 main goals, 1 being 1 billion more people to benefit from health coverage, 2, 1 billion more people better protected from health emergencies, and 3, 1 billion more people enjoying better health and well-being. There are many issues with economic inequality in healthcare. The 4 main issues that cause income inequality is power embedded in social relationships, social exclusion, privilege, and income inequality. The first is power embedded in social relationships. Power embedded in social relationships and exercised through both informal and formal institutions is the fundamental driving force for health inequalities. This issue is derived from income, privilege, race, and religion. Next is social exclusion. According to the International Journal for Equity in Health, social exclusion influences health directly through its manifestations in the health system and indirectly by affecting economic and other social inequalities that influence health. Social exclusion is due to low income, and it prohibits people from receiving health care. This is also connected to social class, religion, and race. Lastly is privilege. Those who are more privileged receive health care, while those who are not as privileged usually cannot afford health care. Issues that can be seen as privilege that affect health care is race, religion, income, and gender. A system of inequality that plays a role in this issue is low income. As we can see on the image in the bottom right, 29% of low-income people cannot afford medical care, while only 6% of high-income people can't afford it. Those who do not make as much cannot afford the expensive cost of health care. According to NCBI, the proportion of Americans with difficulty affording health care varies by income and health insurance coverage. Overall, 16.9% of Americans report at least one financial barrier. Income greatly affects the healthcare inequality. So how does WHO cope with income inequality? Well, the health inequalities are systematic differences in health status of different population groups. They have significant social and economic costs to both individuals and society. No matter what social class or income, the World Health Organization helps those who are in need of health care. WHO gets funded by member states that pay their assessed contributions, and the rest is paid by voluntary contributions. The assessed contributions pay less than 20% of fees required for the WHO to run effectively, so that means that it is mostly voluntary contributions that are being made. The WHO states that the remainder of the WHO's financing is in the form of voluntary contributions, largely from member states as well as from United Nations organizations, intergovernmental organizations, philanthropic foundations, the private sector, and other sources. As we can see in the image, this is a diagram of who the contributions to better lives and health and where they're mainly from. So my call to action for this issue would be to improve healthcare quality and reduce disparities. We need to utilize innovative strategies to provide the right care for each consumer while establishing a consumer-driven stakeholder process that requires plans to be set for a year-over-year target to improve the needy areas. We need to be persistent on this issue. We also need to strengthen oral and mental health care. We need to ensure that critical mental and oral health services meet the needs of all, including people of color and immigrants. We need to support workforce and employment training for mental health providers to help this issue. Lastly, we need to fund proven health prevention strategies. We need to increase the availability of peer providers and community health workers to better support and serve the communities in accessing health care. We need to also increase the access for health care that has been proven to be effective for patients around the world. In conclusion, healthcare equity is a very big deal. Many factors affect healthcare equity. We need more organizations like WHO to help benefit those who are less privileged and cannot afford it. And lastly, we need a voice for healthcare equity. Everyone has a voice, and by speaking out what we think, we can better help save healthcare equity. Thank you for listening to my presentation.